Good morning to everybody. I am Dr. Captain D.K. Ramawat, consultant non-invasive cardiologist from Ramawat Heart and General Medicine Hospital, Barmer. Today we are going to discuss a very good chapter. We are going to discuss the clinical effects of Biosprolol on cardiovascular system. First we will discuss the clinical effects of alone Biosprolol, then we will go to fixed dose combination of Biosprolol with telmisartan, and next we will go the fixed dose combination of Biosprolol with amlodipine, and also we will discuss the other things also, and it is a very good topic. So may I continue? Okay. The clinical effects of Biosprolol on cardiovascular system. The first we will take the growing CAD burden in India. Its prevalence is 11% for non-diabetic patients, means 21.4%. And it is 3 times higher CAD rates in Asian Indians even after immigration. And 1 in 4 deaths in India are now because of cardiovascular diseases with ischemic heart diseases. Showed an escalating trend with 49.8% increase between 2007 to 2017. Now the second slide, here you will find the unique features of Indian CAD patients. Indian CAD patients are younger age at presentation, rapid progression, high mortality rates, and transcendence rising of multivessel diseases, and having diffuse coronary artery involvement, having distal diseases, having significant left ventricular dysfunction at presentation. What is our goal? Our goal of treatment for CAD is reduce the frequency and severity of angina, thereby improving the quality of life. And our aim is to reduce future cardiovascular events, and our aim is to improve survival. Now the third slide. Here beta blockers. We are discussing, of course, this Biosprolol is a beta blocker. Beta blockers well established cornerstone in pharmacological management of ischemic heart diseases. Benefits of beta blockers in CSD are mediated via blockade of beta 1 receptors. Everybody knows that beta 1 receptor is found in the muscles of the heart. So what are the benefits? Blockade, if we block the beta 1 receptor, what are the benefits? First, there is regression of atheromatous process. Second, there is reduction rate of reinfarction. Third, there is reduced infarct size and risk of cardiac rupture. Fourth, there is increased threshold to ventricular fibrillation. Then fifth, there is reduction of platelet stickiness. The sixth, there is reduced myocardial oxygen requirement. So there will be reduced heart rate, reduced systolic pressure, and reduced ventricular contractility. The seventh point, there is reduced heart rate which prolongs coronary diastolic filling pressure, that increases your life, because at the time of diastolic filling the heart rests. People say the heart never rests, but in diastolic filling heart get rest. The eighth is reduced arrhythmogenic free fatty acids, and ninth, the last but not the least, redistribution of coronary blood flow. Now we have come to the fourth slide. Beta blockers using stable CAD. What do you mean by stable CAD? Everybody knows it is a reversible supply or demand related to ischemia according to geographical region. So here we will discuss the NICE report, that is National Institute for Health and Care Excellence. Beta blockers that specify acute coronary syndrome uses in the British National Formulary are included in the table. The most commonly used beta blockers based on National Health Service uses across all indications are atenolol, bisoprolol, carvedilol, metoprolol and propranolol. However, this is not specific to acute coronary syndrome. The committee noted that bisoprolol is used commonly in current practice after acute coronary syndrome. The fifth slide. Here we will find wealth of evidence exists for bisoprolol. Number one, why? It reduces the number of anginal attacks. Second, it offers cardioprotection and reduction in major adverse cardiac events. Third, it is most widely used beta blocker globally, that is bisoprolol. Fourth is efficacious in lowering resting heart rate and major adverse cardiac events. Fifth is largest and longest study with superior mortality reduction. Sixth is commonly used beta blocker for acute coronary syndrome as per NICE, National Institute for Health and Care Excellence. Then seventh point is here for the wealth, significant improvement in left ventricular ejection fraction and significant reduction in heart rate. The eighth point, bisoprolol in arrhythmias may be considered as first choice as per coherent review. Ninth is it significantly reduces mortality and major adverse cardiac events. And the last but not least, bisoprolol in stable angina, which trigger due to exercise or stress, and there is endothelial dysfunction. Now, bisoprolol may be considered as first choice as per coherence review. Then the sixth slide, we are dealing with association of beta blocker therapy with cardiovascular outcomes in patients with stable ischemic heart disease. What is stable ischemic heart disease? That is chronic coronary artery disease is known as stable ischemic heart disease. So, what is objective here? To determine the association between beta blockers and cardiovascular events in patients with stable coronary artery disease. So, now here the patients are taken from the different states, etc., and you can see the here table okay, what they have done. No need to explain. Now, seventh slide. In bisoprolol, there is significant reduction in the composite of all-cause mortality and hospitalization with beta blockers over 5 years in stable ISD. Stable ISD means chronic coronary artery disease. So what happens? Composite of the death, hospitalization for heart failure or MI reduced with bisoprolol. Results primarily driven by reduction in MI with bisoprolol. 8% reduction in the hazards of primary outcome. It is a novel or meaningful outcome. Then beta blocker like bisoprolol were associated with 13% relative reduction in hazards of hospitalization for MI. Now the 8th slide, long-term effectiveness of bisoprolol in patient with angina. Here we have taken a duration of 14 years and we have seen mortality and cardiovascular outcome in different in so many patients that is given in underneath chart. So ninth slide I will tell you there is significant improvement in survival with bisoprolol in patients with angina. There is protective effect sustained over 14 years. So you must know that 55% there is lower risk of mortality compared to other beta blockers and 50% lower risk compared to drug other than beta blockers. Now there is significant benefit found in terms of incidence of angina, embolism, secondary MI and arrhythmias. Now what do you mean by secondary MI? Secondary MI means an acute imbalance in myocardial oxygen supply and demand without atherothrombosis. So this is the 10th slide. Here you will find bisoprolol effectively lowers resting heart rate and causes a significant decrease in composite cardiac output. So here you will find study confirm lowering resting heart rate after bisoprolol treatment caused the lowest number of composite cardiac outcome and it improved the prognosis and improvement is independent of BP lowering effect of bisoprolol. Now in 11th, the bisoprolol is very good in arrhythmias, for example, in supraventricular arrhythmia and ventricular arrhythmias. In supraventricular arrhythmia, it is lowering heart rate and atrial fibrillation also. It also improves symptom and quality of the life. And in ventricular arrhythmia, lowers mortality and reduces the number of hospitalization. Also lowers the burden of ventricular arrhythmias. Now the 12th slide, first slide of this is now I am giving you or telling you take home messages of the first plain bisoprolol effects. What are those? Beta blockers are used in patients with CAD to reduce the harmful effect of excessive adrenergic activation on the heart, because you know that adrenaline and noradrenaline are secreted in the blood and they cause as the excessive adrenergic activation of the heart. Now wealth of evidence exists with bisoprolol in CAD including acute coronary syndrome. Greater mortality reduction in CAD patient, largest and longest real world evidence with bisoprolol. Effective reduction in resting heart rate and major cardiac adverse events in Asian patients with bisoprolol. Improvement in left ventricular ejection fraction and other cardiac functions and parameters in tenacity. Here tenacity is what? Here we have to do the comparison of tirofiban and FCG-MAB and other studies. So the 13th slide, you know the heart failure in India. What is Indus study? Prevalence of heart failure in India is around 1% of the total population. About 8 to 10 million individuals with an estimated mortality rate of 0.1 to 0.16 million per year. And the 14th slide, beta blockers are the cornerstone and integral part of guideline directed therapy for patients with heart failure with reduced ejection fraction. Here, what is the first recommendation in Biosprolol? The first recommendation is start early, and second is adjust accordingly. So start early, do what? We recommend all heart failure with reduced ejection fraction patient, first give beta blocker, secondly SGLT2 inhibitor, third mineralocorticoid receptor antagonist, and fourth ACE inhibitors or ERNI. ERNI is what? ERNI is neprilysin inhibitor, that is sacubitril, plus ARB like valsartan. This is known as ERNI. So either you give ACE inhibitor or ERNI. Then adjust accordingly. In these 4 pillars, you can adjust other 5 things. What are those? Number 1, diuretic you can add. When? Only in hypervolemia. You can add ivabradine. When? When the heart rate is more than 70. And you can also consider digoxin only if there is atrial fibrillation. You can add hydrogen nitrate. When? When there is low estimated glomerular filtration rate. And next what? You can add omurcative mecarbil. When to add? When there is low ejection fraction or hypotension. For treatment of adult with chronic heart failure with reduced ejection fraction, we have to add omurcative mecarbil. And last but not the least, varicose gut. Varicose gut is used when 2.5 mg is used. It increases pumping activity of the heart and relaxes the blood vessels. 15th slide, relative risk reduction with 4 pillars of heart failure therapy. I have already discussed 4 pillars of the heart failure therapy. So here, what is mortality and hospitalization? I am talking about 4 pillars used and what is this result in mortality and hospitalization. If we use ACE inhibitor and ARB, then there is don't discuss, you straight away you go. If we use other beta blockers, then no. If we use Biosprolol, you must see there is relative risk reduction of mortality is 35% and relative risk reduction in hospitalization 41%. And while in others like mineralocorticoid receptor antagonist and ACE inhibitor ARB and ACE inhibitor ARB or SGLT2, this is actually reduction is very less. Maximum is with Biosprolol, that is 35%, and maximum hospital reduction is 41% with Biosprolol. Now, used together, these 4 pillars have a great potential to improve outcome. When all 4 drugs are combined, it has been estimated that relative risk reduction is 73%, with the number needed to treat of 4 to prevent a death when compared to number treatment. Now we go to 16th slide, that is Biosprolol was associated with reduced mortality with reduced ejection fraction patient at all tolerated dose level, and its withdrawal increased the risk of mortality. Reduction of mortality with Biosprolol versus placebo. All-cause mortality was significantly reduced in the Biosprolol group compared to placebo, and treatment withdrawal associated with a significant increase of mortality in bisoprolol group. Now, so what is the result? Result is of the death in patient with heart failure, up to 50% are sudden and unexpected. Indeed, patients with heart failure have 6 to 9 times the rate of sudden cardiac death of the general population. Now, the 18th slide, it is SEBI's second trial. Bisoprolol given in addition to standard therapy significantly reduced all-cause and CV mortality, all-cause and CV hospitalization, and sudden death in stable, reduced ejection fraction patient, and was well tolerated. 54% of patients were treated with bisoprolol in dose of 7.5 or 10 mg. And you can see the chart, SEBI's second key outcome in bisoprolol group versus placebo. Now we switching from carvedilol to bisoprolol ameliorated adverse effects in heart failure patient with dizziness or hypotension and improved the New York Heart Association class. So you can see here, the chart is in front of you, that dizziness and hypotension has been reduced. Now the 20th slide, bisoprolol combined with ERNI in the cardiac rehabilitation of patient with acute myocardial infarction combined with left ventricular ejection fraction after PCI. What is that? Bisoprolol combined with sacubitril valsartan sodium tablet has a good application effect in the cardiac rehabilitation of patient with acute MI combined with left heart failure after PCI. It can promote cardiac rehabilitation and improve cardiac function and reduce the incidence of cardiac adverse events. Now, 21st slide. Here you will see in heart failure, 97.5% patients have comorbidities like diabetes, atrial fibrillation, COPD and CKD. But you must know that 44% of patients hospitalized for chronic heart failure have diabetes, and 35% comorbid atrial fibrillation and chronic heart failure are there. And chronic obstructive disease in chronic heart failure ranges from 10 to 40%, and 20 to 74% of chronic heart failure patients have concomitant CKD. So now this 22nd slide, in patient with coexisting heart failure and COPD, bisoprolol but not carvedilol or metoprolol demonstrated survival benefit with a significantly lower and dose dependent mortality. 23rd slide is in patient with coexisting heart failure and COPD, beta blockers demonstrated significant survival benefit. So bisoprolol reduced the incidence of congestive heart failure and, or you can say, COPD exacerbation by 62% compared with carvedilol. Then the 24th slide, relative to carvedilol, bisoprolol initiation in hemodialysis patients was associated with a lower 2-year risk of death and major adverse cardiac events. In 25th slide, effect of bisoprolol on all-cause mortality was influenced by baseline renal function and was consistent across all renal function groups. This is post hoc analysis of the SEBI's trial. And you can see here that this benefit was realized despite patients with worse renal function. So, this your bisoprolol can be even used with worse renal function. And now in 26th slide, bisoprolol has a favorable pharmacokinetic profile, including the patient with CKD. Bisoprolol is a low dialyzability beta blocker with low risk of hyperkalemia and favorable pharmacokinetic properties. Mixed route of elimination like hepatic and renal. You must know that bisoprolol has got mixed route of elimination like hepatic and renal 50-50%, and its inactive metabolites, hence no accumulation in the blood. This is marvelous. Then bisoprolol balanced clearance is very important, since failure of one clearance organ leads to a maximum twofold increase in plasma half-life of bisoprolol. Therefore, what to do now? Bisoprolol could be the drug of first choice in the treatment of cardiovascular diseases for patients with end-stage renal disease. Now, whatever we have discussed or read, its points of what to take home messages. Number one, beta blockers are the cornerstone in the treatment of heart failure. Bisoprolol has proven efficacy in landmark of severe studies and many more. Bisoprolol is considerably more effective than the other several beta blockers. Bisoprolol appears to be preferred molecule in COPD, atrial fibrillation and CKD stage 5, which is CKD stage 5 means when there is GFR less than 15 ml per minute with hemodialysis. Then fifth number, switching from carvedilol to bisoprolol has been shown to be beneficial and helps in continuation of treatment and reaching target dose. Sixth point here, initiate only if patients are stable or have compensated heart failure. Forget not, initiate only if patients are stable or have compensated heart failure. Here symptoms of stable heart failure, compensated heart failure are fatigue, shortness of breath, edema are absent. Compensated heart failure means these symptoms are absent. For example, fatigue, shortness of breath and edema are absent. Then it is called compensated heart failure. Now the seventh, start at lowest possible dose and titrate to target or maximally tolerated dose. Now 28th slide, why bisoprolol is so unique? Number one, highest beta-1 selectivity. Beta-1 receptor in the muscles of the heart, it acts there. Then minimum impact on lung function, minimum impact on lipids, minimum impact on glucose, minimum impact on male sexual function, minimum impact on peripheral circulation. Then it is consistent pharmacokinetic profile. Then it has got balanced clearance by two routes. It has got less first pass effect and high bioavailability, and its lowest PK variability, pharmacokinetic variability among all beta blockers. Average protein binding, less likelihood of drug to drug interactions. 12th is 10 to 12 hours is the half-life. So you can use once daily dose. Then last, first pass effect means decrease of the active drug concentration at its site of action. Now 29th slide, bisoprolol selectively has a 19.6-fold higher affinity for the beta-1 receptor than for the beta-2 receptor. in the heart muscle. You can see the chart. Beta 1 receptor serves as a receptor of catecholamine, epinephrine and norepinephrine. It is dominant receptor in heart and adipose tissue and is equally sensitive to epinephrine and norepinephrine. And if we block this, there will be more benefit to cardiovascular system. It blocks beta 1 receptor. So now in 13th slide we have concluded biosprolol based combination in hypertension. So in hypertension, if we combine the fixed dose combination of biosprolol with amlodipine, then you see combination we usually use in smokers, obesity, COPD, and high risk for stroke. And with telmisartan, if we use fixed dose combination, then we use in high heart rate and in angina and post-MI and in metabolic disturbances like diabetes mellitus, insulin resistance, dyslipidemia, metabolic syndrome and CKD. And if we combine it with hydrochlorothiazide, we use it in elderly. Now, European Society of Hypertension says what? Initiation of 2 drug combination therapy is recommended for most hypertensive patients. Beta blockers can be used as monotherapy or at any step of combination therapy. Now, biosprolol with telmisartan fixed dose combination, prevalence of sympathetic overactivity in hypertension is blocked. What is sympathetic overactivity? You will find in that condition the restlessness, inappropriate sweating, tremors in hands and fast speech. And in patient 1514, the overactivity was reduced to 62.42%. Sympathetic overactivity was reduced. Now we have come to the 33rd slide, plasma renin guided therapy in patient of primary hypertension in antihypertensives. So here you will see renin guided management caused significant BP reduction, and angiotensin converting enzyme and angiotensin second receptor blocker increases the renin. So most hypertensive subjects had high renin levels, means 45.98% people. And renin is secreted by juxtaglomerular cells of the kidney. It causes stimulation of the corpus luteum, causing vasodilation to reduce BP. So we have understood that renin causes vasodilatation and reduces the BP. Now hypertension in India, special features. Indian hypertensives are sympathetically overactive. So you will find in non-dippers. What do you mean by non-dipper? Those persons who have less than 10% in BP during sleep. Those persons who have less than 10% decrease in BP during sleep called non-dippers, and have obstructive sleep apnea, have high resting heart rate, have high renin levels, and have early onset in life, have clustering of multiple CV risk factors, have early hypertension mediated organ damage, and have significant seasonal variation of BP. So here the use of telmisartan is very important. So thus there is a need of comprehensive neuroendocrine blockade in Indian hypertensive, which is provided by fixed dose combination of bisoprolol, highly selective beta blocker and telmisartan. Most commonly used ARB. The telmisartan is most commonly used ARB, which is this provided by this. Now this is 36th slide. Biosprolol plus telmisartan offers comprehensive neuroendocrine blockade. You see, sympathetic nervous system causes this tremors, etc. So here, if we give beta blockade, then there stops, and if we give beta blockade like bisoprolol, and if we give telmisartan like ARB, then it blocks the AT1 receptor blockage. And AT1 receptor blockage is a subtype of angiotensin second and found in afferent and efferent arterioles, glomeruli, mesangial cells and proximal tubules. AT1 receptor regulate vasoconstriction and sodium and water reabsorption, as well as promote promote cell growth and cell proliferation and collagen matrix deposition. So, prevent reactive renin upregulation, hence used to lower high BP. If bisoprolol is used, to increase renin will be prevented and break positive feedback loop between sympathetic nervous system and renin angiotensin aldosterone system. So this is dual renin angiotensin aldosterone system blockade. Now Indian consensus on bisoprolol and telmisartan fixed dose combination, you can read the chart and go through it. Now 38th slide. Number 1 is stage 2 naive. Naive means without enough experience of life and ready to believe or trust other people. The naive hypertensive patient with high heart rate. Secondly, hypertensive patient with angina, post-amine and atrial fibrillation. Third, hypertensive patient with sympathetic overactivity, means young and middle-aged. Then hypertensive patient with CKD. And then the hypertensive patient with metabolic syndrome like diabetes, dyslipidemia, metabolic syndrome, obesity, insulin resistance, etc. They are all get relief by beta blockade. Now 39th, bisoprolol and amlodipine fixed dose combination. Here you will find treatment with a fixed dose combination on bisoprolol and amlodipine. Results are downward, you can see in the table. Then treatment of hypertension with fixed dose combination bisoprolol and amlodipine in daily practice. Results of multinational non-investigational study. You can see after 6 months of fixed dose combination, 99% have showed excellence or good result adherence, and 16.5 millimeter mercury reduction was found in systolic BP, and 9.5 millimeter diastolic blood pressure decrease was found, and pulse pressure 7.1 millimeter was found, and heart rate decreased 7.7 beats per minute. This is the 41 bisoprolol plus amlodipine fixed dose combination, excellent adherence and better blood pressure control. You will find after 6 months of fixed dose combination treatment bisoprolol plus amlodipine, 82% of the participants of the study showed excellent adherence. 15% the adherence could be considered good, and reduction in systolic blood pressure, systolic and diastolic blood pressure of 11% are seen, and pulse pressure decreased from 58.8 to 52.2. This is excellent and good. So conclusion is, results from the observational study suggest that level of patient adherence to the fixed dose combination of bisoprolol and amlodipine are very high, and that the FDC is well tolerated and associated with favorable effects upon blood pressure. This is the last slide, 42. Other studies of bisoprolol and amlodipine providing cardioprotection. You can read the chart and can conclude. Thank you.